Next paper is Sirolimus coated balloon for femoropopliteal and below knee disease, XTOSI Trial, 24-month results. Authors, Drs. Chok, Yap, and Chong from Sengkang General Hospital in Singapore.
Thank you, Chairman. Good afternoon, everybody. My name is Tek Chong. I apologize for my first two authors. They were frozen by the Arctic wind, so they're not able to make it here. The title of my talk is on Sirolimus drug-coated balloon for FemPop and below knee disease. Is the XTOSI 24-month trial results. Chronic limb-threatening ischemia is a major health burden everywhere around the world. Effective revascularization is the cornerstone of treatment and often hampered by high rates of restenosis and frequent interventions after POBA. There needs to be a better solution to maintain vessel patency. This is the first-in-man clinical trial of the Sirolimus Magic Touch drug-coated balloon, and the results were reported for 12 months previously by Edward Chok before. This is the flowchart of 55 patients starting to be screened by duplex ultrasound and toe measurement. They underwent angiogram angioplasty. 5 patients were not eligible. 50 patients were enrolled. 6-month endpoint, we had 40 patients underwent 6 months primary patency by duplex ultrasound, and you can see we're going to present the 24-month outcomes for 36 patients. Unfortunately, in Singapore, we have an epidemic of diabetes, so 90% of these populations have diabetes. Dialysis rates of 20% are actually low in our population. Usually they're double that, around 40%, and many of them have concomitant coronary artery disease. We don't do a lot of claudication. We do mainly Rutherford 4, 5, 6, and you can see the majority of these patients are Rutherford 5 and 6 patients with a Wi-Fi score of 4 to 8. So the high risk of amputation in these patients. If I then start with the BTK disease, you can see that the primary patency at 6 months was 74%, and at 12 months was 59.1%. At 24 months, it's 50%. So there is sustained BTK patency after 12 months. For FemPop, the data is better, 88% at 6 months, and 12 months is 78.6%. 24 months, it's dropped to 53.3% primary patency. In terms of the other endpoints, freedom from CDTLR, you can see FemPop 93.8%, BTK disease 85.7%. Amputation-free survival 72.4% for below knee disease, which is expected in these patients at high risk for amputation, and all-cause mortality as typical with CLTI patients in the 20% range. Limb salvage is reasonably good at above 90% for both FemPop and BTK disease. In summary, these are promising 12 and 24 month results in which more than 50% of lesions remain patent. These are small sample size, obviously. It's our first experience with the Sirolimus drug-coated balloons. We have the Magic Touch as well as the solution in Singapore. Limb salvage rates are above 90%, and all-cause mortality is expected to be significant. That's why it's 15 to 20%. I'm going to show you some examples of patients. This is quite typical late presentation of patients, the initial angiogram where the Magic Touch balloon was applied. We use duplex for follow-up. It's cheaper in our system and it avoids the use of contrast. You can see that it is able to establish wound healing, and the FemPop segment remains patent. Of course, there's still disease. You can see at 12 months and at 24 months. There is disease progression, which is quite typical for this group of diabetic ESRF patients. Patient is able to walk, obviously with a foot aid, and is able to work as a taxi driver and Uber driver equivalent over here. This is another patient you can see in the BTK disease, specifically in the AT, the horn of the AT. Significant disease to start with, and after application of the Magic Touch, a decent result. Follow-up 6, 12, 24 months seen on the right side there, achieving healing of the amputation, ray amputation site. Recurrence of disease, which is not unexpected, but allowing the wound to heal, and there's no occlusion at the AT. So the other thing that we have noticed anecdotally is the slow flow phenomenon of the paclitaxel-based devices seems to be less prominent in the sirolimus-based balloons. You can see these are typical patients, and then we have to do a primary ray amputation, the baseline angiogram seen over here, specifically focusing on the BTK disease. I think the last image is taking some time. So diffuse stenosis in the AT perineal and CTO of the PT, incomplete plantar arch as shown over here. If you remember what the wound looks like, this is trying to do a below ankle angioplasty, which unfortunately is quite common in our system and in the patient population we treat. So we use the sirolimus drug-coated balloon. In this case is a 3 millimeter for the tibial vessels and then a 2 millimeter for the plantar arch. And the results are quite good. In the middle one shows the post-POBA. The digital vessels are lighting up better and hopefully better flow into the toes. Of note, this is immediately after. The slow flow phenomenon is not that pronounced compared to paclitaxel balloons that we use quite frequently. So this is what it looks like in the tibial vessels, post-POBA and then post-magic touch. And you can see that when one vessel, the PTA, had magic touch applied and the perineal had no magic touch, the flow through those vessels are similar, which highlights the lack of distal embolization by the sirolimus. So we know that for paclitaxel devices, there is a lot of slow flow phenomena, as you see in the image on the right side, in the stented segment where paclitaxel was applied, and there's this chuck flow that doesn't go anywhere. And we check for distal angiogram. Usually there is no disease that's untreated, but obviously there's particulate matter. We now know that it's okay to stop as long as there's no lesion that's untreated, and usually it gets better within 24 hours. But it's still concerning to see this kind of disease, and especially if we use many balloons in the above knee and below knee segments. So anyway, this is the first in man, and this follow-up will be on a randomized trial on the future SFA and future BTK study, treating Rutherford 3 to 6 for the SFA study and 4 to 6 in the BTK study. And the numbers of recruitment are stated there, 279 and 219. So in conclusion, this is the XTOSI trial, and I'm showing the 24-month results, which is promising when you compare to the 6 and 12-month primary patency, the high freedom from TLR rates at 85%, high limb salvage rate at 90%, and ulcer-free rate of 100%. Obviously, we have to interpret these results with caution because of a small group of patients, only 50, and we're awaiting results of these ongoing RCTs. Thank you very much for your attention.
Great talk. I think we're all a little bit jealous that you have some drug-coated technology for pedal and tibial vessels. Any issues with flow-limiting dissections and having to do bailout stenting or anything like that with this balloon?
All balloons have dissections, especially when we treat this kind of very severe disease. For BTK, we don't tend to stent a lot. I think the bioabsorbable scaffolds haven't been that promising. We use short segment coronary stents when we need to, usually in the TP trunk or the AT proximally. But they become expensive, and I'm not sure if they really lead to long-lasting patency anyway. So they're a really tough group of patients. Perhaps the best would be the VESS CLL trial where we all bypass, right?
Well, thank you very much for braving the Arctic winds to get here and share your experience with this sirolimus drug balloon. Now, if I interpret your results correctly, it doesn't seem like the patency rates are all that different than the current paclitaxel balloons in the FemPop, outside for the, maybe a little extra difference in the BTK region. But is there a cost-effective, is this cost-effective? Is sirolimus, I'm sure they're going to be manufacturing with a little bit more expensive than paclitaxel. So overall, is the value reasonable in your experience?
Thanks for the question. It's difficult to answer value because it depends on the health insurance system and the payer and stuff like that. It's very different to our system in Singapore where all consumables are paid for by the patient rather than in the US where it's all reimbursed. That's why we do not have a limitation on where we use the sirolimus or paclitaxel drug-coated balloons because the patient is paying for it. So you're right that the SFA data is not much different than the paclitaxel data. But I think what's different in our group of patients, they are mainly Rutherford 5, and most of the data coming out of the US and Europe would be Rutherford 3, 4 maybe. So our group of patients are quite different, and we have 90% diabetes. So this group of patients are challenging to start with, and you would expect poor results in this group of patients. So I don't know if they're directly comparable, and definitely this is an exploratory study, so I'm not sure this answers any questions yet. In comparison with paclitaxel, I'm not sure the company is ready for us to do any kind of study, an RCT head-to-head with paclitaxel for obvious reasons. So we have to wait to see. Maybe I'll bring some balloons next year.
Dr. Wohler?
Thanks for shedding light. This is a high volume center. You're doing a lot of taking care of a lot of sick patients. Can you shed some light for us on the mechanism, either the decreased mechanism of embolization with the paclitaxel balloons, or the mechanism in general for increased embolization with the, with decrease with sirolimus or increased embolization with paclitaxel?
I think there are many smart people in the room, and you probably can answer this better than me. But paclitaxel balloons came out first before sirolimus balloons. So the carrier and the distal embolization problems were probably not well answered and understood at that time. I think there are many bench studies that show that there is distal embolization with the fluorescent green image that you see from, I can't remember who, about distal embolization. And when we shake the paclitaxel balloons, they flake, because there's some white stuff on the table. For the sirolimus balloons, when you shake it, nothing comes off. But the worry we have is, does anything get transferred to the vessel wall? Because nothing comes off. So I don't know if it's better coating technology. We don't know how much drug actually gets transferred. Obviously, there are pig studies that are submitted for approval. But in humans, we don't know how long they last as well. And I suppose there's also the issue of calcification, which happens a lot in diabetic and ESRF patients, in our group of patients. So again, I don't know really if it makes a difference over POBA. And it's a great question, but anecdotally, definitely the slow flow phenomenon is less pronounced, and we are more comfortable using it in the below ankle area and even in long segment disease.
Very insightful. Thanks.
Okay, thank you.
Thank you.